So today, we're going to trace the story of a part of our own anatomy that went from, just an obscure footnote in a textbook to the absolute center of a major medical debate. We're talking about the perforator veins in our legs. It's a really fascinating story of discovery, incredible surgical innovation, and a big question that doctors are still wrestling with today. All right, let's jump right in.
Okay, so let's start with the problem that brought these veins into the spotlight in the first place, a really painful and persistent medical condition that affects millions of people.
So here is the central question, the big mystery. You've got a patient with a venous leg ulcer, right? It's this chronic wound that just will not close up no matter what you do. For centuries, this was just a frustrating puzzle. What hidden mechanism was stopping the body from doing its job and healing itself?
Well, to answer that, you gotta understand something called perforator veins. Think of your leg's vein system like a network of roads. You've got these small surface roads, those are the superficial veins. And then you have a main highway system, the deep veins. Perforator veins, they're like the one-way on-ramps. They have these tiny little valves that make sure blood only flows in one direction, from the little surface roads into the main deep highway, which then carries it all back up toward the heart.
But what happens when those one-way on-ramps break down? When those little valves fail, blood can actually flow backward, creating a kind of traffic jam. And this causes a ton of pressure to build up in those little surface veins right under the skin. It's this chronic, relentless high pressure that can eventually damage the skin and lead to those stubborn, non-healing ulcers we were just talking about.
Now, what's really wild is that figuring this out, this seemingly simple problem, took an incredibly long time. So let's take a look at how the medical community slowly, piece by piece, put this puzzle together.
The journey started way back in 1794, when these veins were first drawn. But honestly, they were pretty much ignored. It wasn't until 1917 that a surgeon named John Homans first said, hey, maybe these faulty veins are what's causing these ulcers. That idea finally led to the first major surgery by Robert Linton in 1938. And the evolution didn't stop there, with a huge leap forward in 1985 towards less invasive techniques using endoscopes. It was this slow but steady march of progress, taking almost 200 years just to go from identifying a vein to having a modern way to fix it.
Right, so once doctors figured out what to target, the next challenge was, how do you fix it without causing more harm than good? And this is what led to the first major revolution in treatment.
For about 50 years, if you had a problem with these veins, the solution was something called the Linton procedure. And let me tell you, it was a big deal. It involved a very long incision right down the length of the calf to go in and tie off the problem veins. It worked, yeah, but it was a really invasive surgery, and it came with a huge risk of complications, especially on a leg that was already in bad shape.
And this is where you really see the huge leap forward. Compare that open surgery with the endoscopic approach that came next, which is called SEPS. Instead of one massive cut, surgeons could make a couple of tiny little keyhole incisions away from the fragile skin near the ulcer. They'd slide in a camera and tools to do all the work internally. The result? Way fewer complications and a much easier recovery for the patient.
But SEPS wasn't the final destination. While it was a total game changer, it was still a full-on hospital procedure. You needed general anesthesia, a tourniquet to control bleeding, and it was actually pretty tricky for surgeons to learn. The stage was set for another, even bigger revolution.
And that brings us to the modern era, the percutaneous revolution. We're talking about something called PAPS, or percutaneous ablation of perforating veins. This is where treatment moved out of the operating room and into the doctor's office, with the goal of closing the vein from the inside without any major cuts at all. So one of the main ways they do this is with laser ablation. Using an ultrasound to see, the doctor inserts a tiny little laser fiber right into the faulty vein. They inject a special numbing fluid around it that also protects the tissue, and then, zzz, they use laser energy to basically heat and seal the vein shut from the inside. Simple as that.
Then you've got a really similar technique called radiofrequency ablation. Instead of a laser, this uses a specialized little stylet that uses radiofrequency energy to generate controlled heat. It does the exact same thing, seals the vein from the inside, just using a different kind of energy.
And then there's a completely different approach that doesn't use any heat at all, sclerotherapy. For this, a special medicated foam is injected right into the vein. This solution irritates the inner lining of the vein, which triggers a reaction that causes it to collapse on itself, scar down, and close off.
So, what's the bottom line with this whole revolution? Well, for patients, the benefits are just huge. We're talking about procedures done in a doctor's office with just local anesthetic, Patients have very little pain and can literally get up and walk out right afterward. And most importantly, these techniques are incredibly good at closing the vein they're targeting, with initial success rates often well above 90%.
It sounds like a perfect success story, right? We found the problem, and we developed safer, easier, and better ways to fix it. But medicine is rarely that simple. As it turns out, fixing the anatomy doesn't always fix the patient. And that is the heart of the major scientific debate we're going to unpack right now.
And this quote from our source material, man, it just cuts right to the heart of the problem. Despite all this amazing technology and our ability to precisely close these problem veins, the big, high-quality studies have really struggled to prove that doing it actually makes a significant difference in healing ulcers or stopping them from coming back.
Okay, let's actually look at the data from a huge study, the Dutch ulcer trial. They compared two groups. One just got standard compression therapy, like special stockings, and the other got compression plus surgery to fix their perforator veins. Now, the healing rate was a little better with surgery, but not by a ton. But the real shocker was the recurrence rate, the chance of the ulcer coming back. As you can see, the numbers were virtually identical.
Just 1%. That's it. That was the difference. After all that surgical intervention, patients in this massive trial saw almost no difference in the chance of their ulcer returning compared to the people who just wore compression stockings. For a lot of people in the field, this result was a real bombshell.
So here's the crucial point. The evidence we have now suggests that for a lot of patients, the most important things are treating problems in the main surface veins, those major roads in our analogy, and just using good compression therapy. Whether tacking on a specific procedure to close a perforator vein really adds a meaningful benefit on top of that, well, that is still very much an open question.
And this leaves us with a very modern medical dilemma. We have these incredible, low-risk, office-based tools that can fix an anatomical problem with pinpoint precision. But if the evidence is murky on when it actually helps, how do doctors and patients make the right choice? It's the ultimate question of matching our amazing technological progress with proven patient benefit, and it's a debate that is absolutely shaping the future of how we treat vein disease.